Hello everyone, I'm Chiu Yongying, one of the medical officers from Kuteba Hospital. Today I want to share with you our experience in management of a case of bilateral large ureterocele. Ureterocele is congenital cystic dilatation of ureteric orifice. It usually accompanies with duplicated pelvic glycol system and a poor functioning of the duplicated renal moiety. Also, it is often complicated by upper tract obstruction and VUJ reflex of the ipsilateral ureteric orifice. Ureterocele can be classified into two types. If the ureterocele is contained within the bladder entirely, we call it intravesical ureterocele, whereas it is extravesical or ectopic if any portion of the ureterocele extends to the bladder neck or urethra. Ureterocele can be further categorized into the following subtypes according to the number of systems and the type of orifice involved. Some patients with ureterocele are asymptomatic, while others may present with unexplained infection and the symptoms of bladder outlet obstruction caused by the prolapsed ureterocele. So the goals of diagnosis on ureterocele is to identify the type of ureterocele, detect possible VUR and contralateral malformations, as well as the existence of its complications such as infection and compromised renal function. Ultrasound still remains the first-line investigation nowadays because it can not only show the anatomy of ureterocele and the ipsilateral upper tract, but also dynamically detect the existence of reflex and the perfusion of duplicated renal moiety. CT urogram and MRU are also widely used in clinical practice. They can further clarify the anatomy of the urinary tract. The latter one also avoid the risk of nephrotoxic contrast. IVU, although is not commonly seen in the diagnosis of ureterocele, it still provides useful information for the anatomy and shows the reflex dynamically. Here's the summary of our case. The patient is a 44-year-old Chinese female who presented with asymptomatic pyuria and microscopic hematuria. Ultrasound KOB shows bilateral ureterocele but no upper urinary tract obstruction. These are the ultrasound pictures. As we can see, no reflex of either side of ureterocele. Subsequent CT urogram confirmed non-obstructing single-system ureterocele. However, on 1-year follow-up, the patient develops mild left hydronephrosis as shown by the ultrasound. The patient also complained of mild urgency, frequency, and incomplete voiding during flexible cystoscopy checkup. Flexible cystoscopy shows large left ureterocele, which is 3 cm in size, filling and emptying across the left ureteric orifice. We subsequently decided to proceed with endoscopic incision of the left side ureterocele. This is the video of the operation. This is the right ureterocele. Left side. Filling and emptying. And then we did the endoscopic incision of left side with Collins knife. The principles of treatment lie in the management of its complications, such as preservation of renal function, removing source of infection, treating reflux, as well as maintaining continence. If ureterocele is complicated by bladder wall deficiency, a bladder-level surgery is required. There are a few options of treatment for ureterocele, which is based on multiple factors. As for this case, a single cistern ureterocele without obvious obstruction is more fit for endoscopic incision, and it exhibits lower rate of post-operative reflux into the incised ureterocele.